Thank you very much, Professor Savendale, for the introduction. Good afternoon, ladies and gentlemen. My absolute pleasure to participate in the Indian Society meeting, and this is my 5th time in India, and I'm definitely getting addicted to Indian food. So thank you very much, Dr. Day, for inviting me. I'm just going to touch on some aspects on monogenic diabetes, but I would like to throw special emphasis on neonatal diabetes for a single reason, that it is not uncommon in our region, and I would like to share some experience with you from patients of my own clinic at Mafraq Hospital in Abu Dhabi. But before I go and do that, I'd like to announce with extreme pleasure that we will be holding ISPAE 2020 in Abu Dhabi next year. So you are all invited. You are our neighbors in Abu Dhabi, and we rely on your support in enriching the upcoming ISPAE meeting with your presence and experience. So we will be looking for your presence, your abstracts, and presenting your great work from this part of the world. Monogenic diabetes, if we are going to talk about it, I thought I might just divide it initially based on what the underlying genotype resulting in monogenic diabetes. So we can broadly subdivide it into beta cell dysfunction with multiple mutations that you can see either in main genes or down the stream in transcription factors, or we can talk about insulin receptor defects, and we see all those fascinating syndromes resulting in insulin resistance. And what's more recently been exciting in the field of monogenic diabetes are things related to monogenic autoimmunity, where we see autoimmune antibodies triggered by an underlying genetic defect, which is a fascinating area of monogenic diabetes. And if we translate that genotype into phenotype, so we can see the picture of beta cell dysfunction translated clinically as phenotype into MODY or neonatal diabetes, various syndromic monogenic diabetes, and all that group of mitochondrial diabetes. And if we talk about insulin receptor defects, then clinically we all know and have seen examples of severe insulin resistance syndromes that are resulting from underlying defects in insulin receptor genes. And then perhaps many of you have seen or heard about the monogenic induced autoimmunity presenting clinically by either the very well-known polyendocrinopathy syndromes or the more recently known features like the IPEX, STAT3, and so on and so forth. We've heard Tade saying that monogenic diabetes is rare, ranging between 1% to 6%. And I'm not entirely sure that's the case, because when we talk incidence and prevalence, we need to take into account the area where the statistics are coming from. So if we look at Italy, for example, one of the European countries, when people in Italy looked at this cohort of 3,780 children, yes, they didn't find much, and the incidence was about 6.3%. Of those children had monogenic diabetes. But I find it interesting that in Italy, monogenic diabetes is more common than type 2 diabetes. So if we are saying that this is the incidence in Italy representing Europe, look at us. So if you look at this is a chapter that a colleague of mine and myself has written, looking at the different incidents around the world of monogenic diabetes, particularly neonatal diabetes. You can see there at the top the incidence in Medina, a city in Saudi Arabia, where 1 in 21,000 people have monogenic diabetes. And coming to Abu Dhabi, where I practice, we found that it's 1 in 30,000. And that means that neonatal diabetes is 5 times more common in Abu Dhabi compared to Italy or Austria, and definitely more common than United States. I'm seeing strange windows in my screen here. And now it disappeared completely. And I can't remember what the next slide is. So can you fix it here? And make sure the timing is not working while he is working. Okay.
Sorry.
No problem. Okay. Right. Yeah, so that's my message when it comes to statistics. So I think for us clinicians, the most important thing that we need to appreciate is when should we suspect monogenic diabetes? And we all know these guidelines about what are the major clues clinically that we suspect monogenic diabetes. So we all know that diabetes in the first 6 months of life is extremely unlikely to be type 1 diabetes. Patients who have extra pancreatic features are likely to have monogenic diabetes, absent islet cell autoantibodies, and then all what Tadej talked about in glucokinase, for example, mutations, and presenting with mild, stable fasting hyperglycemia, and if there's a strong family history of diabetes without the typical features of type 1 or type 2. So for type 1, obviously, it's unlikely if there are no islet cell autoantibodies. Type 1 diabetes is a severe insulin deficiency, so if we are still seeing C-peptide, then we are suspicious that that's not type 1 diabetes. And of course, the two major cardinal features of type 2 diabetes, namely the obesity and features of insulin resistance, mainly acanthosis nigricans. So what's new in monogenic diabetes? We've heard about the ISPAE guidelines 2018. There are few new things about screening strategies, there are new things about therapy, and there are new causes and new genes. So there's a lot of hot topics in monogenic diabetes. I'm not going to go into details about the ISPAE guidelines because it was presented by Tadej, but just few things that I have flagged up in red here. So if we have diabetes in a patient presenting before the 6 months of life, then genetic testing is mandatory. If we have children presenting between 6 and 12 months of life, then again, the genetic testing should be considered, particularly if islet cell antibodies are negative. And then the diagnosis of MODY, they were beautifully talked about by Tadej. Now, coming to the screening strategy, this is an interesting part of diagnosing monogenic diabetes, and we can all do it differently. So if we have a child with clear picture of that phenotype, say Wolcott-Rallison syndrome, for example, which is fairly common in our area. So here is a child who's presenting with neonatal diabetes, has abnormal liver function, has skeletal dysplasias, then this is very likely that it is a specific syndrome, and in that one we can select the gene and target the genetic analysis. However, if there are no specific clues to what type of monogenic diabetes that is, then using next generation sequencing has been shown quite helpful. And this is a publication by the Exeter group led by Sean Ellard, showing that the targeted next generation sequencing provide highly sensitive method for diagnosing the underlying cause of monogenic diabetes. This is another interesting study from Norway where people looked at the antibody negative children who are thought to have type 1 diabetes, and a percentage of those children were shown to have monogenic diabetes proven by genetic analysis. And this is interesting because 30% of those children were not recognized clinically. So there must be a group of children in our clinics whom we are treating as type 1 diabetes, yet they do not have type 1 diabetes, but they have some sort of monogenic diabetes. Now, talking about this fascinating science of having monogenic diabetes within population of suspected type 1 diabetes, that will lead to a logical question. Shall we screen for them? Do we screen for them routinely or selectively? And that can be a very nice question for a debate. So people will discuss the pros and cons for routine analysis of monogenic diabetes. So people who are pro screening of monogenic diabetes, particularly MODY, here when talking about, people might claim that, well, MODY, some subtypes are clinically undifferentiatable from type 1 diabetes, so yes, it's worth screening them. And also, people might say, if the child has MODY rather than type 1, then that will save him and the healthcare professional from doing the annual testing. So saving money and saving hassle and extra clinic visits. And also, some treatment, like we've just have seen, some forms of MODY respond to sulfonylurea, and it's fantastic, stopping insulin and going for sulfonylurea. And in some parts of the world, it can be affordable with these less expensive panels. But we need to remember and be realistic that in real life, type 1 diabetes is the most common type of diabetes. And we need to remember that no matter how new genetics are coming to light, MODY remains rare. And if we are talking about the globe internationally, genetics tests are still expensive. And perhaps if a debate session will be running, maybe the people who are against routine testing will be winning. This is another study that's claiming that with the routine testing of the autoimmunity negative might be beneficial, and the authors claim that there are health benefits as well as cost effectiveness in doing that. So this is a study that advocates testing. And I find this study published by the Exeter Group really interesting. The idea of this study is people have gone back to the Guthrie card that were used for neonatal screening of 11 children who were diagnosed with neonatal diabetes. And when people went back and pulled the Guthrie cards from the neonatal screening and looked at the glucose within that study, interestingly, it showed that the glucose was right up from the 3rd to the 5th day when we do neonatal screening. But do we translate that in advocating? Shall we do or shall we add neonatal diabetes to the neonatal screening program? I'm not sure if the answer is going to be yes to that. So why are we making a fuss about monogenic diabetes? Why is it important that we know about it? Well, obviously, the most important thing is that we know and we can explain other associated features. We can predict the clinical outcome, we can master the genetic counseling, and also we can put the right diagnosis. And nowadays, in the modern era of medicine, we all talk about precision and individualized medicine. And I find neonatal diabetes a very good example of applying pharmacogenetics. So we know that pharmacogenomics is the understanding on how specific genes or genetic structure affect response to medications. But if we come to pharmacogenetics, then we are talking about how a single gene defect responds to a single medication. And there are many very nice examples in neonatal diabetes in this phenomenon of pharmacogenetics. One of them is this. So KATP channel mutation is very well known that it responds nicely to sulfonylurea. So one genetic defect, KATP channel mutation, and one medicine, sulfonylurea. And it's not debatable that the medicine works very well in people with KATP channel mutation, allowing successful switching from insulin to sulfonylurea and completely stopping of insulin in these kids. And this is important because in a study done by my colleague Abdelhadi Habib, he looked at two cohorts, 88 children with neonatal diabetes from our region, the Arab region, and he compared them with 77 children diagnosed in the UK. And what he found is the underlying pathology is very different. Although all these children have neonatal diabetes, but our cohort in the Arab region showed that Wolcott-Rallison syndrome is the most common type of neonatal diabetes. However, in the UK, the most common cause for neonatal diabetes was KATP channel mutation. And this is a very important finding because although it's easily to explain, Wolcott-Rallison syndrome is an autosomal recessive disease and we have high rate of consanguinity, which I assume it might be similar to India. However, in the UK, that's not the case. And this is important because if people are thinking about trials of sulfonylureas in children with neonatal diabetes prior to genetic confirmation, then it will help as to where this child come from. It might give you a clue. Having said that, we do see KATP channel mutation in our region. This is a little child who was referred from us from Al Ain, a nearby emirate, to Abu Dhabi. She presented in shock and severe ketoacidosis with a pH of 6.9 and hemoglobin A1C at 12% at 5 months of age. She had no C-peptide detectable and she has negative autoantibodies. Genetic testing confirmed that she has KATP channel mutation. And I was very nervous treating her because that was my first experience switching children from insulin to sulfonylurea, but it went on beautifully. And this child is now 7 years of age, enjoying normal life with half a tablet of glibenclamide, running a HbA1c of 5.4 when I last saw her. So this is in the same line of how good these selected patients can respond to sulfonylurea if the diagnosis was made and applied correctly. And then I would like also to discuss with you another very interesting example of pharmacogenetics in neonatal diabetes, that is thiamine-responsive megaloblastic anemia and diabetes syndrome, where these children were found to respond beautifully to thiamine. So do keep in mind those children who present with diabetes and megaloblastic anemia before 6 months of age or later on with negative autoantibodies, and that anemia is refractory to iron treatment, it might be worth thinking that this might be a syndrome of thiamine-responsive megaloblastic anemia, because again, applying the interesting concept of pharmacogenetics, these children do very well when they are shifted on thiamine. And this is again Abdelhadi Habib, my colleague, who has written this paper showing a cohort of children who responded very nicely to thiamine and showed the impact not only on their anemia but also in insulin. And now if we talk about Wolcott-Rallison syndrome, where I feel it is very well within my comfort zone, because we have the highest number of children in our clinic in Abu Dhabi of this particular syndrome. I've never seen this during my 15 years of training in the UK, and I've seen about 32 patients in a span of 3 years when I relocated to United Arab Emirates. So Wolcott-Rallison syndrome is a very interesting disease caused by mutation in this transcription factor, and it's a horrible disease to have. The diabetes in this disease is just impossible to treat, and these children, they have intermittent liver failure, kidney failure, they have skeletal dysplasias, and the minute they have flu or temperature, their transaminases go sky high. And in this family, where we have diagnosed 6 children, 5 of them actually died with liver disease. I've seen the only surviving child just 2 days ago, and she didn't look very well. She's extremely short, failing to thrive, have multiple skeletal deformity, and her HbA1c is very high. Her blood sugar is either in the 400s, and if you try to intensify her insulin regime, she has unpredictable hypos, so a very challenging type of diabetes to treat. And the reason why I'm highlighting this is that there are implications, because these children with Wolcott-Rallison syndrome, they have high tendency to liver failure and death from liver failure, even from a simple febrile illness associated with otitis media. So again, Abdelhadi and I wrote this at the Hormone Research in Pediatrics, showing the most common associating features in this interesting disease, highlighting that liver disease is the most common cause of death in diabetes. So back to the idea of why do we diagnose monogenic diabetes? We do because it alerts us to other associating factors. So here, liver is the cause of death, not DKA or severe hypoglycemia. What's new in therapy? There's, in the news recently, 2018, this came out not in a medical journal initially, but in a magazine, actually, talking about a child who, with Wolcott-Rallison syndrome, who had liver, pancreas, and kidney transplant for Wolcott-Rallison syndrome at 2 years of age, and 6 months later, the child has done very well, and he was completely off insulin. I do have one child who survived the disease after having a liver transplant at 6 years of age. He is also doing well. So even without gene therapy, there are other things that we can offer to these children. When we talk about new causes of monogenic diabetes, I'm really excited to share this case with you in my remaining 2 or 3 minutes. So this is a little girl who was referred to our clinic at 9 years of age. This girl presented initially with eczema when she was 11 months, and then she started getting recurrent infection and diagnosed with dysgammaglobulinemia at 2.5 years of age, then diagnosed with autoimmune anemia and generalized lymphadenopathy when she was 3, and at the age of 4.5, diagnosed with autoimmune thyroid disease as well as growth hormone deficiency, to progress having juvenile rheumatoid arthritis at 6 years of age. At 7 years of age, she had inflammatory bowel disease, and at 9 years of age, she came with us with a type 1 diabetes. So this is a child with a textbook of illnesses, poor girl. And with her being 9 years of age, there's no chance that these are happening with bad luck in combination. There must be something to link them in common. So there was this feeling that this is likely to be an underlying genetic cause for her autoimmunity, and her diabetes was associated with antibodies. So she did have, by definition, type 1 diabetes along with the others. And genetic testing showed that she had mutation in insulin interleukin-2 receptor. And this is a very interesting story, the monogenic diseases triggering autoimmunity. You might have heard about STAT3 mutation, which are more known and more common. But this child had mutation in interleukin-2 receptor. And what the interleukin receptor 2 normally does is it suppresses self-immunity. So if you have mutation in that, the suppression is gone. And the system starts triggering autoimmunity in the thyroid, in the bowel, in the pancreas, and it results in this consortium of diseases presenting in this girl whom I showed you how she progressed from one autoimmune disease to the other. This is my last slide, just to share with you a new gene that was described recently. And the story behind that is I had a child who was referred to us for insulin pump therapy. And this child was around 6 years of age when he was referred to us. Now, the history is extremely important, regardless of how advanced we are becoming. We need to have a good history. And this boy had diabetes when he was 3 months of age. He was born small for gestational age, and he had no autoantibodies. Now, this boy, he also had short stature, chronic steatorrhea, so multiple extrapancreatic or exocrine pancreatic function. CT scan of his abdomen showed that he has no pancreas, so he said, okay, well, this is straightforward. This is pancreatic agenesis leading to monogenic diabetes, and it must be one of the well-known BFO1 or others leading to pancreatic agenesis. And every single gene tested negative. That was about 7 years ago. So people at Exeter, they kept some of his DNA, and more recently, there were some children with a very similar presentation, with some attention deficit disorders. Some of them have features at the MRI, but they came up with this fascinating mutation of C0, which is the first time that is described in human. It's well known in mice, where it causes diabetes, as well as encephalopathy, and this is the first time where a similar gene leads to a human disease after knowing it in animal models. I thought that's exciting. And I stopped getting depressed when I send a sample and I get a reply, no mutation detected, because I know there will be something more exciting coming out of that sample. So to summarize, ladies and gentlemen, in the last 40 seconds I have, monogenic diabetes is a heterogeneous condition caused by multiple mutation. It is rare, but probably is underdiagnosed. It's very important to make the diagnosis because it influences our clinical management and screening of monogenic type of diabetes. We never know. It might become routine in the near future. Thank you very much for listening.
Thank you very much, Asma. We have time for one question.
Yeah.
Yes, please.
So, Professor Deeb, thank you very much for this exciting talk. It's quite fascinating. So, we in India share a similar clinical and genetic dilemma because of the high risk of consanguinity, the high incidence of consanguinity. So, I just wanted your input on one policy that we follow is where the clinical phenotype is not very characteristic, or rather where the exons in the genes which we need to test are more than 6. So in India, the cost of sequencing each gene by Sanger's, looking at an exon each time, is about 150 dirhams per exon. So if we have more than 6 exons in a gene and there is no categorical phenotype, we would rather run an NGS where the cost would come to about 900 dirhams cumulative. So what is your take on this strategy that for the genes with larger exons, should we be using next generation sequencing as a first pass strategy, or should we be still looking at individual gene first based on clinical suspicion? Because there are quite a few conditions like the PDX1, the ITPR3, which we see, which are not a part of the Exeter initial screen panel, which are not very glaring to the eye on clinical examination.
That's a very good question that I'm not sure I'm the best person to answer I am not a geneticist, but I still feel strongly that our clinical sense should be a priority, regardless of what resources and what facilities are. So if you have a child whose clinical picture is screaming at you or of a specific disease, and there are multiple, then it will be logical that you target that gene and do it. Having said that, we hear increasingly that all these genetic diseases and the genetic diagnostic tests that you are talking about is becoming cheaper and cheaper. And there are multiple panels nowadays that have become more available and much cheaper. And I would like to take the opportunity to highlight for people who do not know about Exeter Lab that they are still doing it free of charge for neonatal diabetes, not for MODY. So to summarize your question, and again, I'm not sure if I have the best answer, is we cannot replace our clinical sense and the good history and a good clinical examination. And the good news is that these genetic panels are becoming cheaper and cheaper.
And maybe also add that the Exeter panel initially covers only the KCNJ, ABCC8 and the INS gene. And as Professor Deeb pointed out, both the Arab world and Asia have a high prevalence of neonatal or monogenic diabetes of the non-3. So it's quite often that the first turnaround after 14 days is that, hey, we've not found anything.
This is a very important point.
And then
it's the wrong panel for our population.
Yes.
So we don't see lots of KATP channel, which is the first target that centers in Europe and America target. So we need to come up with something
our own panel, probably.
Our own stuff, yes.
Thank you very much, Dr. Deeb. Thank you again.